And especially currently in this world pandemic that we're going through, Bayer has decided to shift its strategy to keep the education moving, because they don't believe that if something happens, they sit down, they get up and they actually find other ways to keep sharing knowledge. And I think by sharing knowledge in this platform for the world, it is truly a humbling experience and an honor for me to represent Bayer, but more importantly, an honor for me to represent the great people of the medical community around the world and through all the nations. So anything you need, please let us know. We're open for questions and answer time now. Also, we have my website, mdct.com.au. Jump online. It's all free and access for information, and it works in every country of the world. So thank you so much. And now we'll open up to question and answer time. Kedar, thank you so much for the big thank you. Aurora, yes, it is my absolute pleasure. Thank you so much. And don't worry about missing the liver webinar. I'm sure you can find the link to watch the rerun. Kedar, thank you so much for your gracious thanks. And do we have any more questions, ladies and gentlemen? Now, I would like to ask a question, everybody. Please, on your social media accounts, share these free webinars for Bayer. Because like Bayer is sharing it, I'm sharing it through my MDCT platforms. We as colleagues, we should share things that are for free, because, you know, going to these conferences, they cost a lot of money. And so by Bayer doing it for free for the world, you know, this is very respectable. So it's really important. Please keep sharing it. Share everything, right? Do some screenshots if you want, or, you know, share some, some slides or everything. So please, it's really, really important. So I have a question from Anil Bahia. Do you use intravenous furosemide in your renal onco protocols? To be quite honest, no, I don't. I know that there are a few studies out there that have used this, but I've been quite lucky that with all my studies, we've had some good results and good clarifications. Kuku Nurakoyo, thank you so much. I really appreciate your gesture. Thank you, Jihan. Purawantu, thank you so much, and especially for the great questions. It was a pleasure. Kelly Ann Wells, thank you. From Trinidad. Oh, welcome to our great Trinidad fans. Thank you, Kelly Ann. I really appreciate it. And thank you so much for being online. Please share, you know, our seminar series. This is going to happen weekly from now on, ladies and gentlemen. Thank you also to you, to Pitachaya. I really, really appreciate it. Henry Leung, okay, we have a question. When you use test bolus technique, do you worry about contrast excretion in the collecting system while scanning? Oh, perfect question. Great. So whenever I do my test bolus technique, I only use 5 mils of contrast and 40 mils of saline. 5 mils of contrast does not show up in the collecting system. It's too busy circulating. So excellent question. Mansoor Sattar, what do you tell technicians do mistake while in the renal procedure? What do you mean, what do I do, or what do I tell technicians? Look, guys, you know, no one is perfect. Patients are not all the same. But if we go through the checklist and we teach them properly, our junior staff, believe you me, they will pick up these technical pitfalls and issues before you do. And by doing this, it's our obligation to teach. Now, I'm going to say something which is a little bit sensitive, but, you know, I believe in this. We have a lot of senior radiographers and radiologists, you know, that don't teach the younger generation, you know. And guys, let me tell you, one day you're going to become a patient, or someone you love very dearly is going to become a patient. We hope that doesn't happen. But if that does happen, and you had that junior radiographer in your hospital or your clinic, you never trained them properly, and say you're in a holiday somewhere else and your daughter got sick, or your son, or your mother or father, and you know deep down you didn't train them properly, you know, that is moralistically something we need to really start considering. We have an obligation to each other as humans to teach people, to give back to society. to give back to our people, because you don't know what's going to happen. For example, me, I live all over the world. I'm sharing all of my knowledge wherever I walk. And if you know me, or if I've taught you at any point in time, I know that procedure is going to be done well, and I'll be rest assured, and so forth. All right, so Sarah Dang has a question. Does scanning the patient prone affect the secretory phase? Oh, great question. Well, with the coughing technique, you know, this is where, because you got to remember the kidneys, they sit at 35 degrees. So they're always, this upper border is posterior and the anterior border is anterior. The only time you do a prone technique is only good when you're looking for bladder and you suspect something. But if you did my technique using 100 mils of contrast 370, 200 mils of saline, and a 10-minute delay with the 3 minutes before those 10 big coughs, you'd never have to do a prone at all, okay? Because the contrast won't just pull in the prone system, it would fill up the bladder quite a lot. Chavrat, he has a question. Thank you very much for the useful information and case sharing for yesterday and today. It is my absolute pleasure. Al-Dinari Sanani, thank you to you. Konga Sin, thank you so much. Khan Nguyen, you're fantastic. Hope to see you soon in Vietnam in my Ho Chi Minh City's Children's Hospital. Yes, we went there and would love to go back. I love that place. Nelson, thank you once again. And thank you from the Philippines. To my great team in the Philippines. I love you guys. And more importantly, I love your Bo coffee. So after this webinar, I'm going to have your Bo's coffee, which I brought back from there. Aurora, thank you. Yes, about the obligation statement we have to each other as humans. Romal Kang, institutions are into using less contrast as possible. Absolutely. Yes, I agree with you. So with the CTA protocol, we can reduce up to 40 mils if you want. But when we're looking at oncology, you know, we have to think about how we enhance this. So it's really up to you. Arben Paul, thank you. It was really informative. Where can I find details regarding the future sessions like this? Well, Bayer will be sending out this. Also, if you connect onto my social network, mdct.com.au, I will be also posting them weekly. Okay, but it's going to be the same time and same place. So our next webinar series is actually going to be on the, I'm just going to look up my diary. Give me 1 second, because it's all going to be the same time, same place. So it's going to be, the next one is going to be on Wednesday, the 8th of April. Okay, everybody, 8th of April is going to be the next seminar, and everybody is going to, same time, same place for the next 2 months, okay? Every Wednesdays, same time, same place, everyone, okay? Okay, Uber, how if the kidney is with a GF, this is Uber from Indonesia, hi Uber. How if the kidney with the eGFR below 30 and referrals needed for CT with contrast med, how to manage this? Great question. So what I do is, 48 hours prior, I get a patient to actually drink 3 liters of water per day. Okay, no coffee, just drink water for those 2 days. And what I would do then is I would refer them back to their renal physician, because they might have to go through hydration therapy or they might have to use hydrocortisone. Now, what happens then is if it's below 30, we can't give contrast. It's too dangerous, whether in CT or MRI. But then the doctor has the call, if we look at risk versus benefit, to save that patient's life, then we go ahead and we give contrast, but we can give smaller volumes. Sarah Dang, thank you so much. Hope to see you again in Sydney soon. Actually, I'll be in Brisbane, hopefully at the end of June for our next conference, but nothing in Sydney this time because the people in Brisbane are very upset with me because I've been in Perth, Melbourne and Sydney and never come to Brisbane. So I'll be there, don't worry. Henry, okay, fantastic. Henry is another great question. For detecting stones in the renal system, do you prefer using contrast scan or just use a plain scan? Oh, this is a whole lecture on its own, and that is a fantastic question. So if a patient has bleeding, microscopic or macroscopic hematuria, I'll go into the 4 phases because it could be tumor related or you just don't know. If it's just renal stone and there's no microscopic or no macroscopic hematuria, Pre-contrast KUB, kidney urinary bladder, is more than enough, okay? Kong A Sin, do you explore contrast media usage in oncology and PET CT? Absolutely. So there is a paper that I wrote up in the editorial in the Society of Nuclear Medicine, where we're actually now using contrast media in PET CT. So instead of having a CT chest, abdomen, pelvis, and then you come back and you have a CT and a PET CT, what we're doing now is we've created a big study where we use the Intego, which is the biggest study in the world. I published this in Academic Radiology last year, where I looked at 1,000 patients. I did a weight-based protocol for CT, and in actual fact, I got the radiation dose a lot lower in PET CT with FDG using the Intego, which is body weight protocol 2. I got a lot lower compared to normal CT. So now with contrast protocols and techniques now to be actually to do this. So excellent question. Sarah Dang, are there any CPD certificates available in this? Well, at this time, no. But I'm sure next time we can start exploring this definitely and get this for our customers. Jian Yang, how do we decrease contrast volume when the patient only has one kidney? Fantastic. So if the patient has one kidney, guys, just split it in half. You only need half the contrast volume. That's all I will say. Because what happens is because it's only 1.5 liters a minute, or 1.34 liters a minute of blood that's going through both kidneys. Well, if you're only using half of it, you only use half, or you can drop it by 25%. But remember, the body with one kidney can also function as like two kidneys. It becomes, really hyperactive in the way it's working. So that's good. Right. Any other questions? So the next one is going to be on the 8th of April, and we're going to start with head oncology CT. This is going to be fantastic. I tell you what, this oncology series, I'm actually going to take it just to the next level, because this is something I have taught around the world, but I actually redid all my presentations to show you things that we have invented, which really are going to make a difference in the world. Great. So everybody, I'd like to thank you all so much. We have no more questions. I really appreciate it. A big thank you to you all again, and Bea. And now I will sign off and hand you all over to Yi Won, who is in Singapore. And thank you so much, everybody. And I look forward to seeing you all in a couple of weeks for another heavy 2 months of education, where consistent image quality through consistent contrast delivery with good contrast and safe contrast can make a difference in our patients forever. Thank you all so much, and take care. Goodbye.
Thank you, Dr. Chabel, for your valuable and wonderful lecture again today. And thank you all participants for joining the CT protocol optimization webinar today focused on the renal. We really appreciate for your attendance and active participation by sending numerous questions, and these are all valuable to us. Before you leave, on the bottom of the screen, there's a green box with a chart icon that you can click on. Once you click, it leads to short survey questions regarding today's webinar. So we would greatly appreciate if you can give us honest feedback on today's webinar. We have another webinar series for April that's coming from, that's actually going to start from April 8th, just as Dr. Chabel mentioned now. So please stay tuned for more further information. Thank you all very much, and hope to see you in 8th of April. Thank you.